Well, good evening, everyone. Excellent, thank you. Loud and clear. Welcome, everyone. Just having a look in the chat, can see there's people from all over the place this evening. So very warm welcome. You're not making us jealous at all in Lanzarote. Orkney, Gibraltar, Dublin, Hampshire, Yorkshire, Cornwall, Manchester. Very good. So we're very UK based at the moment. I'm sure there'll be some from abroad. Norfolk. Oh, we were in Norfolk last week. So welcome, Anita. And Fab. And another from Orkney. Yes, the Halfords. Welcome along. Nice to see you both. Good to see the familiar faces along, and welcome along to our free weekly webinar again. Cold Basingstoke, cold London as well. I've just got in. It's to defrost the car 2 days in a row. I'm not sure I like this. So excellent. So welcome along. It's Wednesday evening. It's 7:30, so it must be webinar time. So welcome to our free weekly webinar. We are STC Training Solutions. We're a pre-hospital care training provider based in the southeast of England, just outside Aylesbury. We do FREC 3 and 4 plus all the add-ons. And as of spring 22, hopefully FREC 5 all going well. So just a quick point, those of you that get the weekly newsletter will know that there is a section on our website to register interest in the FREC 5, and we can send you updates if that's something that interests you. We're looking at May for our first course. So this evening then, ECGs. ECGs are my personal favourites, my area of interest, cardiology. So hopefully if you've got any questions this evening, I can do my best to answer those for you. Those of you that haven't met me before, my name's Sinus. I am a paramedic practitioner by trade. So I currently work in a GP surgery down the southeast of England. Used to work for London Ambulance Service, full-time, still bank, and also bank with South Central over the counties in sunny Berkshire. So tonight we're going to be looking at some ECG basics. This webinar series was put together for people that were doing their FREC 3 and FREC 4 courses, predominantly FREC 4 courses. And of course, that's the first time that you're introduced to ECGs, if this is something that's new to you. And I think it's fair to say it's an area that most people get a little bit worried about. It's an area that some people struggle with, and it is an area that you're examined on as part of your FREC 4. One of the exams that you have to sit on the last day of your FREC 4 course is around ECG rhythm recognition. So and that's more than certainly why people worry about them. So they are a bit like a language. I always tell people when you're learning ECGs from scratch, don't dive into the hardcore stuff straight away. It is a language. Learn how to say hello and goodbye and ask for a cup of tea and all that type of stuff before you start, talking fluently. So we need to spot the basics first. And tonight is first of two-part series where we look at the real basics of ECG interpretation. So tonight we're going to focus more around what actually the ECG is showing us, and next week then we're going to look at some of the funky rhythms that can happen when things aren't quite right in the heart. So we're going to do things slightly differently tonight. So I know the quiz is really popular. So there is a 10-question quiz again this evening. So as many of you as possible to join in on that. The prize is, of course, 10% off any of our courses, and we will honour that 10% off of our FREC 5 course when that gets up and running. So so the winner tonight will get a discount code for that. So far we've had 4 winners, so and 3 of those have gone on to book courses, so that's really good. So so what we won't have tonight is the quiz in between, just because it's not going to flow particularly well. So I'll do the talking and then we'll have the quiz, and then of course we'll do something a little bit different next week. So welcome along anyway. So a few of you still just dribbling in, so you haven't missed anything yet. Welcome along to this evening. As I say, we are a FREC training provider, so we do have some courses coming up. We are a bit inundated at the moment, which is great, but if you are looking at doing your FREC 3, there are only a couple of spaces on our next course left now. 2 spaces on our 20th of November course. Our December course is full, and our January course is starting to fill up, so do get booked in if you want to do your FREC 3 anytime soon. FREC 4, we've got 1 space remaining this year. That's on the 22nd of November course. Otherwise, you'll be looking at January. There's space on our ILS on the 12th of December. That's your annual requirement if you have your FREC 4 or FREC 5. And if you're interested in doing SARM, those of you that have FREC 4 and work for a CQC organisation, we've had an extra date just because our November course filled up really early. So you've got the 18th and 19th of December, just the weekend before Christmas. if anyone fancies coming along for a weekend of Psalm, and I'm teaching that one. So not sure if that puts you off or attracts you, but there we go. All the prices on the screen there. There are some offers on. We've got the Zero to Hero package deals. If you want to do more than one course, there are savings to be made. And of course, there will be more when FREC 5 gets up and running. So do have a look at our website if that's something that interests you. So let's get on with it then. So the series so far is all on put my teeth back in. The series so far is all on our website. If you go to the CPD section, you can have a look at all the videos that we've done so far. Just bear in mind, CPD Requirements video was using old data that's been updated. We will be remaking the CPD Requirements video because we get a lot of questions about that. So we've talked about anatomy and physiology. We talked about some common pathophysiology, which is the study of disease. We've talked about maternity care, talked about patient assessment, paediatric assessment. We did sepsis. Last week we did oxygen and Entonox guidelines. Tonight, first of 2 parts on ECG Basics, and then we're going to finish this series with intermediate life support. And by popular demand, the SARM medications refresher. Those of you that have the SARM qualification we'll be looking at any changes that have gone on over the last year. And of course, there have been a couple. So tonight, cardiac physiology, how does the heart work, the electrical conduction system, basically what do the electrics do and how do we interpret them? Where do we put the leads? How do we look at, how do we try and figure out, how do we localize problems within an ECG? So we'll look at the ECG layout. We'll look at the 6 rules of normal sinus rhythm, and we will just talk this evening about abnormal rates. So, and then next week we'll talk about all the other funky stuff that you need to know for your FREC 4 and beyond. We want tonight to be interactive. Charlotte is out on an ambulance, so she's not able to join us again this evening, but she is but do throw in the chat any questions you've got, and I'll keep an eye on it as we go through. At the end, of course, there will be a Q&A session, and if you do think of something you wish you'd asked, you can always email us, text us, or tweet us, or send a carrier pigeon. We'll do our best to get back to you. So we are going to use Mentimeter for the quiz this evening. As I say, there is the prize of 10% off any of our courses if you win. So go to menti.com at the time, and you'll have a code to put in, and you can take part in that quiz. It'd be really good if we can have all 60 odd of you in. That'd be great. Recommended reading for ECGs. I mean, ambulance care essentials and ambulance care practice are the core text for FREC 3 and FREC 4 respectively. The 12 lead ECG art of interpretation, for anyone that has an interest in ECGs, I do recommend that book. If you do one of your courses with us and you buy it on the course, you get 10% off any of our books. But if you'd like us to post one to you, they're available to buy from our website with free postage. I think off the top of my head, they're 55 quid. Or yeah, about 55 quid. Absolutely worth it. It's my favorite ECG textbook, and absolutely worth the 55 quid if you're interested in ECGs. The one in the middle, available to buy from our website. So let's get going then. So the heart is the kind of center of the cardiovascular system. So I'm not going to go into too much detail because we've covered this in cardiovascular pathophysiology and physiology back at the beginning. So the heart is made up of 4 chambers, 2 atria, 2 entrance halls, and 2 ventricles. The atria, their job in life is to contract the blood, to contract and to pump the blood into the ventricles, to pre-fill the ventricles as much as possible, because ultimately we want as much blood in the ventricle when it comes to contract in order to have really good cardiac output. And cardiac output is, of course, the stroke volume, i.e. the amount of blood with each pump times by the heart rate, and we'll come on to cardiac output later. So obviously the most efficient cardiac output is going to be accomplished when we pre-fill these ventricles as much as possible. So that's what the atria's job is. Now the atria need to contract, and then there needs to be a short pause, doesn't there? If you contract the atria and the ventricles together, clearly blood's going to go all over the place. And you have a series of valves to stop blood going backwards. So blood can only travel in the direction it's supposed to travel in a healthy heart. Okay, obviously people with valve diseases may have other issues, but I always tend to start when you're asked to describe blood flow through the heart. I tend to always start in the right atrium. That's a sensible place for me. So blood arrives in the right atrium, not particularly under any high pressure. That's just residual pressure from diastole. Blood pressure arrives in the right atrium from the 2 vena cava. So the superior at the top, the inferior at the bottom, they are the main vessels, the main veins of the body that bring blood back to the heart. So that's where blood pools in the right atrium. From there, it travels through the tricuspid valve into the right ventricle. Okay, so the atria contract. So the right atrium and the left atrium contract at the same time. Then they squirt the same amount of blood into their respective ventricles. and the right atrium squirts into the right ventricle, where blood obviously gets ready to be ejected into the pulmonary circulation. So the right side of the heart deals with deoxygenated blood. You can see on all these kind of medical diagrams, it tends to be drawn in blue, doesn't it? So deoxygenated blood on the right side of the heart. From there, it's squirted out into the pulmonary artery to the lungs. It comes back through the pulmonary vein into the left side of the heart. So one of the things that I see commonly when people label diagrams of hearts and cardiovascular systems is they get confused by the colouring, don't they? So they always just assume that a blue kind of vessel is a vein and a red vessel is an artery. The rule to be aware of there is that if blood is traveling away from the heart, it must be traveling in an artery. Okay, that's the rule that never changes. So blood leaving the heart does so in an artery. Blood coming back to the heart does so in a vein. Okay, so just because this one is shaded blue doesn't make that a vein. That is still the pulmonary artery because the blood is leaving the right ventricle and it's going to the lungs. It's going away from the heart. Blood that is then coming back into the left side of the heart does so through a vein. And just because these veins are shaded in red, because they're oxygenated now, it's been to the lungs, hasn't it? This blood has left the right ventricle, pulmonary artery to the lungs. It's had some gas exchange going on. It's picked up oxygen, it's dumped its carbon dioxide, and it's coming back red. It's not really red, it doesn't really go blue and red in real life, but it does go darker when it's deoxygenated. So this is coming back bright red in the pulmonary vein. So the vein is carrying blood back to the left atrium, so the next entrance hall. So the left atrium passively fills when it's time, when the electrical conduction system says so. That contracts. It contracts at the same time as its right atrium, and it ejects the same amount of blood as the right atrium is into the right ventricle, but it injects it into the left ventricle this time. So one important thing is blood never travels from the left to the right hand side of the heart, except when you've got other kind of underlying disease. In a healthy heart, blood never travels from the right to the left of the heart. It only gets to the left side of the heart once it's been to the lungs and back, and then it only gets back to the right side of the heart once it's been to the systemic circulation, it's been to the organs. So the left side of the heart deals with oxygenated blood. It receives it from the pulmonary veins, from the lungs. It arrives in the left atrium. The left atrium contracts, fill the left ventricle. When the left ventricle is nice and full and ready to go, that contracts out through the aorta. The aorta is the biggest vessel of the body. It's the main artery leaving the heart, and it supplies everything. Ultimately, it bifurcates, it separates, it splits into smaller arteries and goes off all over the body. One of the important things to note, which we'll come on to in a second, is the circulation to the heart itself, and they're one of the first few branches off the aorta, and they're protected by this by the aortic valve. So as the aortic valve opens, it shields the entrance to the to the coronary arteries, because obviously this is where blood pressure is highest during ventricular systole, which we'll talk about in a minute, when the ventricles are contracting. Blood pressure in this early part of the aorta is the highest it's ever going to be. So if you then blast that down the tiny little coronary arteries, clearly you're going to have a problem. So it's a really good design feature there of the aortic valve, just to open up and shield the entrance to those coronary arteries. But we'll come on to that in a bit more detail in a minute. So that's fundamentally it. If you're studying at FREC 4, you are expected to know the names of the valves, more so as you go into FREC 5, of course. There are four sets of valves, should I say, in the heart. So you have the tricuspid valve over here, which separates the right atrium from the right ventricle. Clearly, it doesn't allow blood to flow back from the right ventricle to the right atrium. That's the wrong way. It's not supposed to do that. So the tricuspid valve sits over here. This is also known as the right atrioventricular valve, which makes sense, doesn't it? It's between the atrium and the ventricle, and it's on the right-hand side. The next valve we come across, if we're using my logic of starting in the right atrium, is the pulmonary valve. So that's nice and easy to remember because it's at the entrance to the pulmonary artery. So that stops blood flowing back into the right ventricle. Clearly, what we want to do is that the ventricle contracts, pumps blood in here, that valve shuts, and then this starts to fill from here through the tricuspid valve. It doesn't fill through the pulmonary valve. That would be wrong. So it goes to the lungs, it comes back, pulmonary vein into the left atrium. That's passive. Once the left atrium is ready, it contracts. It contracts through the mitral valve. That's also known as the bicuspid valve. It's also known as the left atrioventricular valve. Medicine's easy, right? We just give everything 3 or 4 different names and then laugh at people that can't remember them all. So it's so easy. But yeah, the mitral valve is probably the most common name. It's known by bicuspid less so, and left atrioventricular valve. You hardly ever hear it referred to that, but that is its true name. Left ventricle, you can see that left ventricle, whilst it has the same volume of blood, this diagram doesn't quite do it justice, it has the same volume of blood in it when it's ready to contract, but it's much more muscular. You can see that the muscle around the myocardium, which is the heart muscle, around the left ventricle is much thicker than it is on the right. Main reason for that is the left ventricle has to pump a lot further. The left ventricle has to pump to the top of your head, to the bottom of your toes, and everything in between, whereas the right ventricle only has to pump to the lungs and back, which in body terms is only a few centimeters, really, isn't it? So much less powerful, the pressures are a lot less, but the volume is the same. Good. So right atrium, right ventricle, pulmonary artery, pulmonary vein, left atrium, left ventricle, aorta. And the valve there, the last valve that we didn't mention there is the aortic valve again. The pulmonary and aortic valves are nice and easy because they're just at the entrance to their respective vessels. Good. So layers of the heart. The heart is a muscle. It's a muscular bag. Okay. The main functional part of the heart is this middle bit, this myocardium. Okay. Hence why when we hear the term myocardial infarction means death. Myocardium is heart muscle. Death of heart muscle is a heart attack, an MI. So, but the heart itself is actually 3 layers. Okay, you have this lovely thick layer of myocardium. It's much thicker on the left-hand side than it is on the right, for the reasons I've just said. You have a thick fibrous layer on the outside known as the pericardium, which is actually split into 2 layers. So you have the parietal pericardium and the visceral pericardium in much the same way as you have the parietal pleura, visceral pleura, parietal peritoneum and visceral peritoneum around the stomach organs and the lungs, respectively. So, and between this, you have a small area of serous fluid and a potential space there. That potential space between the 2 layers of pericardium is, if that fills with blood or fluid, so that'd be pericardial effusion. If it was fluid, it would be cardiac tamponade if it was blood. So that's what we mean by those terms. So, and of course, if you get fluid in that area, then the heart can't contract quite as efficiently and you start to reduce your cardiac output. We'll come on to that term again in just a second. So the bulk of the heart wall is myocardium, myocytes, which are specialist cardiac muscle cells. Now, the importance with the heart to bear in mind is that it responds very well to electricity. Controlled electricity causes controlled contraction. It causes the heart to do what it's supposed to do, which is beat. But it needs electricity to do that. Without electricity, it won't do anything. So that's the important thing to learn first of all. And then we have this Teflon layer on it, a nice thin endocardium. It's a nice Teflon layer, non-stick surface. When blood stops, it clots. Okay, so we don't want blood to stop at any point. We want blood to glide nice and gently past the endocardium. It's a nice non-stick layer. When that starts to deteriorate in the vessels, for example, with arteriosclerosis, etc., as in the buildup of ischemic heart disease and coronary artery disease, that's when you start to get friction, you start to get the blood slowing down at the lowest layers, you start to get blood stopping. As I say, when blood stops, it clots, and that's when you start to have kind of problems with MIs and things like that developing. So good. So they're the 3 layers. Most important, absolutely, is the myocardium. So the blood supply to the heart, here's the aorta, here's the first couple of branches off, which are the left and right coronary arteries. Okay, they travel down the left and the right hand side of the heart, nice and easily. We generally consider the right coronary artery to be 1. If you speak to some cardiologists or people that know a bit about cardiology, we often start to describe the right coronary artery as also splitting into the marginal branch and then the right posterior ascending branch, because it goes up the back and ascends, it goes up. So, but generally speaking, we consider the right coronary artery just to be 1 artery. With the left coronary artery, we do always consider it to split. So it's the left main stem where that splits. It goes to the circumflex, which wraps around the side, and then you have the left anterior descending, which travels down the front, anterior front, descending, going down. So what's the point of knowing this? So this is something that I think when people start to get their head around it, there's a bit of a eureka moment. And when we start to look at ECGs and trying to find where the problem lesion is or what's actually going on with the heart, we start to look at inferior, anterior, posterior. We'll talk about all this in a minute. And that's when you can actually start to think about which blood vessel might actually be at fault, because these blood vessels tend to serve very specific areas of the heart. You can look here. So actually, I'll flip back slightly. When we're doing ECGs of the heart, which we'll come on to views in just a second, when you're looking at the heart, we can generally only look at 3 sides of it, and we can look at the anterior wall, which is the front wall of the heart. We can look at the anterior wall quite easily. We can look at the bottom of the heart, which is known as the inferior wall. So the bottom of the heart is down here at the bottom of the right ventricle into the left ventricle. And then we can look at what's called the lateral wall, which is this left side of the heart, okay? We can also look at the posterior wall, but that's not covered at FREC 4. That's additional lead placement, which we're not going to cover tonight. But that would be, that is another way we can look at the heart, although we don't do it very often. So the main ones are anterior wall, lateral wall, and the inferior wall. So those three views are served by very specific arteries. So if you look at the right ventricle, the right coronary artery, particularly down here at this marginal branch, you can see that it's supplying this bottom wall, the inferior wall of the heart. So the right coronary artery is generally associated with inferior wall problems. The left coronary artery, because it splits in two, is a little bit more complicated. So the left anterior descending is the easiest because it's got the answer in it. The left anterior descending serves the anterior wall of the heart. And the left circumflex is the last one out, and it serves the left lateral wall of the heart. So they're the three views we get of a standard ECG: inferior, anterior, and lateral. And that's right coronary artery, left anterior descending, which you'll hear called the LAD, and the circumflex, which does the lateral. Hopefully that's making sense to you. When we're talking about coronary artery disease, if you're not sure what we mean by those terms and acute coronary syndromes and all that jazz, go back to our cardiovascular pathophysiology lecture from several weeks ago. Have a refresh on that. But what we're talking about here is these coronary arteries. These coronary arteries become blocked. If they become blocked acutely, so we call it acute coronary syndrome. One of those acute coronary syndrome, or two of those acute coronary syndromes are different types of heart attack, okay? And heart attacks is what we're going to be using the ECG predominantly for. We're screening in a little way for heart attacks. So I told you that the myocytes, the cardiac muscle cells, respond really well to electricity. So we need to have a coordinated way of distributing that electricity, don't we? So this is the conduction system. Honestly, the cardiovascular system was designed by somebody special, because they really have covered all bases with it. It's an amazing system. So the electrical system of the heart starts here at the SA node. The SA node is the boss, all right, boss of the workshop. He shouts go, everybody goes, or he shouts fire, everybody gets on with it. All right. So when the SA node fires, the SA node sends a little electrical signal. It travels down through lots of bundles and things like that. We'll talk about that in a minute. And what happens is basically all the cardiac myocytes start to contract. Obviously, we have the electrical conduction system set up in a way that we don't fire the atria and the ventricles together. I'll show you how it does that in a very clever way. But generally speaking, the SA node is what makes the heart beat. So as the SA node fires, electricity travels down, and the heart contracts. Okay, so we have what's called internodal pathways, but basically the electricity travels from the SA node to the AV node. First of all, that's its first journey. This atrioventricular node at the bottom of the right atrium is the kind of next most important player. So I've told you one golden rule to remember is that myocytes respond very well to electricity. The second golden rule you need to know to understand ECGs is that electricity can only go from the top of the heart to the bottom of the heart. So it can only go from atria to ventricles through the AV node, okay? Electricity cannot travel through here, it can't travel through here, it can't travel through there. It can only go from the SA nodes to the AV node, and then from the AV node, then it can travel down to the ventricles. Now, that's really important. I'm sure some of you are guessing it already, because otherwise, if electricity could just travel from the SA node all the way down to the apex of the heart without stopping, you would just get the atria and the ventricles contracting at the same time, and nothing would really work. So it's really important that electricity can only go through the atrioventricular node. If you've got a real passion for ECGs, then by all means go and look at our older ECG series where we went into a lot of things around Wolff Parkinson White and nodal reentry tachycardias and things like that, which go into what actually happens when electricity is going into the ventricles from somewhere other than the AV node. It's a mess. It's an absolute mess, but yeah, that's something you can have a look at. So for a healthy heart, SA node fires, electricity travels across both atria, because we want the left atria to beat as well, and it does that through Bachmann's bundle. Bachmann's bundle is an electrical pathway that goes over to the left hand side of the heart. You also have pathways for it to travel down to the AV node through the right atrium as well. So anyway, SA node fires, atria contracts, electrical signal travels down to the AV node. Now the AV node holds on to it, it puts the brakes on. And it does that because we don't want the ventricles to contract just yet. So the AV node holds on to that electrical signal and it gives rise to something called the PR interval. I'll talk to you in a little bit about that in a moment. When you come back and you start learning about heart blocks, when you do your FREC 5, you'll learn a lot more about the AV node and problems associated with it. For now, we just need to know that the AV node puts brakes on the electricity. The electricity arrives there, but it's not allowed out until it says so effectively, and it should be a defined time. 120 to 200 milliseconds is how long it's going to hold on to that electricity for. So then it travels down through the next bundle. The next bundle is called the bundle of His. The bundle of His splits into the left and the right bundles. Okay, the bundle branches. Many of you may have heard of left and right bundle branch block. I'm not going to go into what they are tonight. That's above the scope of a FREC 4. But ultimately, that's when these bundles, they don't conduct electricity. So of course, you can start to think about how the electricity might have to migrate in different directions and cause ECG anomalies. But we're going from the AV node into the bundle of His, into the left and the right bundle branches. From there, it dissipates into something called the Purkinje fibers. The Purkinje fibers are basically just the terminal ends of those little copper wires, if you imagine them as being copper wires. They kind of fizzle out into the cardiac myocytes just to make sure that every last one is reached. Okay, so if you want to think of the bundle of His as being like the aorta, the left and right bundle branches as being like your femoral arteries, and then your Purkinje fibers as being like the tiny little capillaries at the end of your toes, if you want to think of it in that kind of anatomical way. So the electricity is traveling through massive big core cable all the way down to tiny little strands of copper. So SA node fires, atria contracts, AV node grabs that signal and holds onto it until the ventricles are ready. Then it releases it clearly as it travels down the bundle of His and the two bundle branches into the Purkinje fibers. Both ventricles contract. That's health, isn't it? SA node, atria contract, AV node releases, ventricles contract. So there we go. It's basically what I've just said, isn't it? So you have this cardiac cycle. There's some terminology you need to be aware of here. So there's systole and diastole. Everybody's probably heard of that. If you've done your FREC 4 and you've learned to take blood pressures, you'll be aware of what they basically mean. Systole is the pressure of blood in the heart when the heart is contracting. Systole is the heart contracting. Diastole is the heart relaxing, and it's the residual pressure in the arteries when your heart is in that relaxed state. But systole is actually two parts. We can only measure ventricular diastole, when we're taking blood pressures, but there is also an atrial systole. An atrial systole is quite simply just the pressure of blood as it's being contracted by the atria into the ventricles, and then ventricular systole is the one that we measure with our blood pressure machines. Diastole, of course, being the relaxation stage. So actually, the electrical conduction system of the heart, how does it overlay cardiac systole? So SA node firing and signal traveling between the internodal pathways down to the AV node is going to cause atrial systole. Okay. Once the AV node releases it and the signal travels down the bundle of His, bundle branches and off to the Purkinje fibers, you're going to get ventricular systole. When the whole system is resetting, the heart is going to be in diastole because it's not being told to do anything. It's got to reset, so it all just relaxes. It's a muscle at the end of the day. If you tell it to contract, it does so, and then it relaxes passively. That's the heart in between. So I've talked about this term cardiac output. Cardiac output is heart rate and stroke volume. Heart rate is controlled by a number of ways, hormones, and more kind of quickly so anyway, is the central nervous system. You'll all be familiar with parasympathetic and sympathetic nervous systems. The way to remember them, I always think parasympathetic nervous system sounds like paramedic. Paramedics are there to calm you down. Parasympathetic nervous system calms you down. It slows everything down, puts you in a rest and digest, relaxation state. Whereas the sympathetic nervous system is your fight or flight. It speeds everything up, and the heart is very simply wired within that. It has a wire from the sympathetic nervous system. It has a wire from the parasympathetic nervous system. Whichever one is shouting the loudest gets listened to. If the sympathetic nervous system starts shouting, the heart speeds up. Parasympathetic system starts shouting, the heart slows down. Okay. At rest, the heart has a bit of parasympathetic nerve kind of innervation going on at all times. It's known as vagal tone. If the heart is left to its own devices, it'll beat at about 100 beats per minute. Now, most of our resting heart rates are a bit lower than that. And that's because the parasympathetic nervous system is usually putting the brakes on slightly. That becomes important when you learn about drugs like atropine if you go off and be paramedics and nerve agents and all that type of stuff. So, but yeah, so generally speaking, at rest at the moment, my heart rate is probably 70, 80, something like that. It's because my parasympathetic nervous system is just holding the brakes on very slightly. If I were to go and jog, don't choose to do it very often, but then the sympathetic nervous system is going to take over and my heart's going to go over 100. Stroke volume, not a huge amount we can do about our stroke volume, to be honest. That is kind of fixed. It's just being healthy and doing lots of exercise, but the bigger your stroke volume, the better. But of course, we can adversely affect our stroke volume when our atria don't contract properly, and conditions like atrial fibrillation, where the atria aren't contracting in a coordinated way, is going to reduce your stroke volume. So they're the two ways to affect your cardiac output. Clearly, we want our cardiac output to be as good as, to be within predefined levels at all times, otherwise our blood pressure would be too high or too low. But of course, we want our stroke volume to be as good as possible so that the heart rate doesn't have to be as high, so that the heart runs efficiently. Okay. When you see people with high resting heart rates because they're unfit, it's because their stroke volume is generally relatively low. Okay. So that's what we mean by cardiac output. Here's what the ECG waves look like. So I apologize if it's the first time you've ever seen anything like this. It is a bit much to take in, I'm sure. But let's break it down. It's really quite simple. This is what we would consider to be a normal ECG printout, if you like, a normal ECG group of waves. Okay, and I don't know who labeled it. I'd like to meet them and ask them why they didn't just use A, B, C, D, E. But there we go. We started at P for some reason. So the P wave, is then followed by the QRS complex. So at this stage, at FREC 4 stage, you don't need to understand what the individual Q wave, R wave, and S wave actually are. You just need to be aware that there is so that the three of them combined are known as the QRS complex. So you have a P wave, a QRS complex, and then you have a T wave. A T wave is shown at the end here. So this is the one that looks a bit like a roller coaster. So P wave, QRS complex, and T wave. I want you to, just for the moment, to forget about J. Just forget why J is written in there. Okay, I will come back to that briefly, and we'll talk about that next week. And I want you all to forget about U waves at the moment. U waves are in here just to show you that they can appear. It's not fully understood what a U wave means, but they often appear when patients have too much potassium in their body. So, but at this stage, you don't need to understand U waves. It's not completely clear, whether they're useful or not. So the SA node firing, the SA node fires and electricity travels to the AV node. That's what gives the P wave. Okay. When the AV node holds on to that electrical signal, that's what we get this PR interval. So this little flat space here. So that PR interval is the AV node holding on to that electricity so that the ventricles can pre-fill. The QRS complex is the yeah, fair enough. Yeah, I like that logic, Anthony. Yeah. So the QRS complex is the electricity traveling down through the bundle of His, bundle branches into the Purkinje fiber. So that's the ventricles firing. Atria contracting, pause, ventricles contracting. The T wave is everything resetting. It's the myocytes repolarizing. So you depolarize when they contract, they repolarize when they're relaxing. So P wave, QRS complex, and T wave, that's all you need to take away at this stage. All right. I will come back to what J point means. In fact, let's cover it now, just because it is the most logical place. So what I want you to do is just this picture. I think is really good. It really sums up all the different waves. So the PR interval starts at the beginning of the P wave and ends at the start of the QRS complex, effectively. Okay. So the PR interval is the time taken for electricity to get from the atria to the ventricles and then be allowed to proceed for the ventricles to start depolarizing. That has to be a set between a kind of set parameter, and I'll go into those parameters shortly with you. The QRS complex, as I say, don't worry about the individual waves. They are three that become one. They are the ventricles contracting. We want that to happen nice and quickly. The ST segment then is the next term that you'll need to be aware of, and that's this flat bit here between the end of the QRS complex and the beginning of the T wave. That should be a nice flat area, okay? The start of the ST segment, or the ST interval, or the ST segment, sorry. The start of the ST segment is also known as the J point. Please don't ask me why, I have no idea. But there you go. I think probably the person that invented it had a name beginning with J. But so we just need to be aware of that. That terminology does come up, okay? So the ST segment, the start of the ST segment is known as the J point. Now, I will talk about this in more detail next week when we talk about funky rhythms, but ultimately, if that ST segment rises, or another word could be elevates, we get an ST segment elevation MI, okay? ST segment elevated MI, STEMI. It's our diagnostic heart attack, okay, and that's what we're looking for. So this ST segment, you can see here that it starts what we call isoelectric. If you're not sure where your isoelectric line is, look at the line when the P wave starts. If the line where the P wave starts is at the same place as your ST segment, you are normal. If that is raised by more than one square, it's generally significant, okay? And the J point, when you hear people saying that the J point is raised, they are basically just saying that the ST segment is elevated, okay? We often say the J points are raised when we don't want to call it a STEMI. So we're basically saying the ST segment is elevated, but I'm not calling this an ST segment elevation MI because unfortunately, like all things in medicine, there are lots of reasons why your ST segments might elevate and you not be having a heart attack. So me personally, anyway, if I say, well, the J points are up a bit, I'm saying, well, it looks abnormal, but it's not a heart attack. So, but that's that you'll hear J point mentioned quite a lot. And then the T wave is everything resetting, as I say, should look like a roller coaster. So you'll hear the other term that you'll hear shortly is the QT interval. The QT interval is the time between the start of the QRS complex and the end of the T wave. And basically we're looking at, with the QT interval, that everything resets within a reasonable amount of time. Okay, so let's come on to what normal is very shortly. Of course, the slides will be up on our website if you want to download these and have a look at them later. I just want to go through, why would you do an ECG? Why would you do an ECG? I mean, the obvious stuff is chest pain and or dyspnea, means breathlessness that can't be readily explained. I think everyone kind of thinks of chest pain, don't they? Why would you do an ECG? They've got chest pain. Good. Unstable patients where the cause is not immediately known. That's another one, just because you want to. And again, the reasons here for ECG indications. Now these are harvested from a couple of trusts I work for and some other guidance I can find online. So it's an amalgamation of guidelines that I've worked from. This is just because we're telling you to do an ECG doesn't actually make you, it doesn't mean you have to understand what we're looking for at that particular time. It just means that would be an indication for an ECG, and if the paramedic turns up, that's what they're going to want, so you might as well get it in the meantime. So a patient that's unstable, by that I mean their blood pressure is low and we don't really know why, or they're very unwell, we don't really know why. Transient loss of consciousness, the good old T-lock, or first presentation seizures, again to rule out cardiac cause. Oh, what happened there? There we go. Unexplained falls in the elderly, again, to rule out cardiac cause. Palpitations makes sense, doesn't it? Because we want to make sure we haven't got any arrhythmia like atrial fibrillation that you're going to learn about next week. Abnormal pulses, we will talk about slow and fast tonight. So abnormal pulse below 40 or over 150 or newly irregular. Again, we'll talk about irregular pulses next week. But so an abnormal pulse would be a reason to do an ECG. Drug overdoses, somebody mentioned antipsychotics. Tricyclic antidepressants are an absolute nightmare for the heart. There are loads of drugs, to be fair, that are taken in excess absolutely knacker the heart. Don't forget, cocaine is one of the big ones. So recreational drug use, if the patient consents, they should at least be offered an ECG if they confide in you that they've taken recreational drugs in any dose. But any drug overdose, even simple things like paracetamol can mess up your heart in sufficient doses. Diabetics with unexplained symptoms because of peripheral neuropathy, because of the problems associated with chronically high blood sugar. They don't always feel pain in the same way. So they don't always get chest pain when they have a heart attack. So we should do an ECG on a diabetic that's unwell and we don't know why. But I think the golden rule you just need to be aware of is that a normal ECG, of course, does not rule out ACS. You can have NSTEMI. That is still a heart attack. It will still kill you, but the definition of NSTEMI is non-ST elevation MI, i.e. the ST segments haven't raised, i.e. the ECG might be normal. Okay, probably won't be, but it might be normal. So you can, in theory, have a normal ECG and be having a massive heart attack and die 5 minutes later. So just because they've got a normal ECG, it doesn't mean that we can relax, all right? But if they have an abnormal ECG, it absolutely strengthens your case for this patient being unwell. What's the significance of this? Anyone want to chat through it in the chat? We're going to talk about ECG lead placement. Why have I put that picture up? Yes, good. I like that, Matt. Absolutely. ECG rules things in, not out, whereas biochemistry rules things in and out. Absolutely. Yeah, so it's troponin, isn't it? It's what we're looking for. Ride green. Ride your green bike, electric bike, left ventricle. No. Stop overcomplicating. Ride your green bike, Barry, I like you. Right, okay, good. So ride your green bike is how we're going to remember where we put our leads if we're using European machines, which I'm assuming most of us are. So good. Well done, Peter. Yeah, ride your green bike. So what that means is, so we're going to start from the patient's right shoulder. Ride yellow, green, blue. Red, yellow, green, blue. Yeah, absolutely. Good. Perfect. So, and it's black actually, black at the end. So what we're going to do is we're going to look at the patient. We're looking at the patient. The patient's right, so it's going to be your left. Okay, from the right shoulder, we're going to work clockwise and we're going to put the limb leads on. Okay, so red, yellow, green, and black. So red on the right shoulder, yellow on the left shoulder, green on the left hip, black on the right hip, or wrists and ankles as the alternative. So we will talk about lead placement just now. So I've also put the American color scheme up here. So if we're using the European color scheme, this is red here, this is yellow, this is green, this is black. Hence the ride your green bike in a clockwise way. But the American color scheme, if you pick up some old Zols or life packs and things like that off eBay, I've got a Zol M series which I use at work for doing ECGs. Good as gold, but it's got the American set of leads on it, so the American color scheme is very different. But the good thing the Americans do is they put on it RA, LA, LL, RL, so right arm, left leg, right leg. Lead placement is a bone of contention. Okay, I've always been taught it doesn't really matter as long as you do the same on both. So you can either go for wrists and ankles, or you can go for shoulders and hips. Okay, wrists and ankles, but you can't mix and match between the two. So you can't do wrists and hips or shoulders and ankles, okay, because that will distort the view. But you can go to the beginning of each limb or to the end of each limb. All right, it's entirely up to you. Now, I've always been taught, and I've been taught by some pretty good cardiologists, that it actually doesn't matter that much. I've not seen any substantial evidence really that makes me disbelieve that. So what I will tell you though, particularly in the pre-hospital setting, patients that are a bit uncomfortable or they're a bit fidgety or cold, or they've had seizures, or et cetera, and not particularly compliant, you won't get very good ECG readings if you use the wrists and ankles. Hence why in the ambulance service, you tend to see most people using shoulders and hips. There's less muscle between the shoulder and the heart than there is between the wrist and the heart. Okay, any muscle between the electrode and the heart has got the potential to give you artifact. But artifact is just kind of noisy data from other electrical signals, because all your muscles in the body give off some form of electricity when they move. So for clearer traces, you'll probably find that shoulders and hips work better for you in the ambulance setting. But you'll see in hospital, most of our in-hospital colleagues use wrists and ankles. Some people have been told you absolutely have to do it one way or the other way. I mean, from what I can tell, that's not true. You don't have to do it one way or another. You do what works for you or what works on the day. One thing that isn't up for debate, though, is the chest lead placement over here on the left. So the 12-lead ECG is made up of 10 ECG electrodes. Okay, nice and confusingly. 4 limb leads and 6 chest leads. The 6 chest leads go in order, and they can only go in one place. All right, female anatomy does tend to get in the way of the chest leads, and sometimes we do have to make some kind of some allowances for that. So now the perfect chest lead placement is all done on intercostal spaces. So you want to be in the 4th intercostal space either side of the sternum. and then you need to find the fifth intercostal space. So how do we find those? On a skinny person, it's nice and easy. Okay, you feel down from the jugular notch, so the last little squidgy bit where you get to the top of the sternum. If you feel down a little bit, you'll get to a little bony prominence, a little bony ridge. That's known as your angle of Louis. Okay, as you go either side of your angle of Louis, you can see it here. That's the second intercostal space. Okay, so the second intercostal space is either side of the angle of Louis. If you then feel down another rib space and another rib space, you're going to end up in the fourth intercostal space. Either side of that, you're going to put V1 and V2 in that order. V1 on the patient's right, V2 on the patient's left. Then I would say the next easiest one to put in there is V4. V4 is going to go into the fifth intercostal space in the mid-clavicular line, so halfway along the clavicle in the fifth intercostal space. Okay. The next one I tend to put on is V6, because all we're going to do is follow the fifth intercostal space up into the mid-axillary line. So draw a line from the middle of the armpit down, and that's going to give you the mid-axillary line. That's where V6 is going to be. Now the V3 and V5 are dead simple because they go between the others. So V3 goes between V2 and V4, V5 goes between V4 and V6. Nice and simple. So put V1 and V2. So find your angle of Louis, count 2 more rib spaces down, fourth intercostal space, either side of the sternum, V1 and V2. Find your fifth intercostal space, go to the mid-clavicular line and stick V4. Then carry on round the fifth intercostal space to the mid-axillary line and put V6, and then backfill V3 and V5. Those aren't for debate, really. Those aren't up for debate. They have to be roughly there, otherwise you'll distort the view. Big boobs. What do you do about big boobs? I mean, there's generally speaking, what happens is you generally get V1 and V2 into a fairly good place. V3 to V6 tend to go a little bit low if there's excess breast tissue. What I tend to say to people is actually where the underwire of the bra tends to naturally sit is generally where you want these stickers anyway, but you want them as close as possible to where they should be. But we shouldn't really be sticking them over breast tissue because it can distort the views again. It can reduce the voltage and make your readings a bit unreliable. So they should go under breast tissue as close as possible to those anatomical landmarks. All right. There's always the question about, do you have to expose the breast in order to do an ECG? No, you don't. I never normally ask, or never normally have patients take their bras off for ECGs. You can get V1 and V2 at the center of the chest. And as I say, V3 to V6 are generally going to go underneath the underwire. The underwire actually just holds them in place quite nicely. So you don't normally need to fully expose your female patients to do ECGs. Of course, it does help, like anything, doesn't it? It does help if you've got no clothes in the way, but for dignity, we try not to do so. So here we are then. We're coming into ECG layout now. Let's have a look. What's snow on grass, smoke on fire? Oh, I like that, Brian. I'd never heard that one before. So there's a good one for you guys if you're using American ECG leads. The American way is snow white on grass, which is green. Smoke is black on fire, which is red. I like that. I'll have to remember that one. So heard it here first. Good. Okay, so the ECG layout. This is a typical kind of A4 ECG printout that you'll get on an in-hospital or a GP surgery printout, for example. This is just like our ones. What you find with the life packs and the Zols is you get three. So we get 3 layers. So we've got excuse me, what am I trying to say? So you've got 3 different lines of printout on the Zol and the life pack. So and then you have what this 4th one is at the bottom here is something called a rhythm strip. So with the life pack and the Zol, that prints out later, so that'll be next to rather than underneath. With the standard 12 views of the ECG, they're just going to come out as these top 3 rows on the smaller printers. If you've got the bigger printers, the A4 printers, then you're going to get this 4th row as well, which your rhythm strip at the bottom. So we're going to have a little look at them. So you can see that they are numbered. These are 3 seconds each, and the entire row is 12 seconds in total. So you can see that this top row here is 4 different views of the heart. All right. So this is 3 seconds. This is another 3 seconds. This is 3 seconds. This is 3 seconds. They are all different 3 seconds, if that makes sense. This is 1 to 3. This is 4 to 6. This is 7 to 9, and this is 10 to 12. Okay, but if you look up and down, they are the same. So this is the same beat as that one, as the same beat as that one, but that's not the same beat as that one. Hopefully that's making sense. The row below, you can see we've got lead 2. We've also got 4 views there. We've also got 4 views there. That's what I'm saying. If you look up and down, these are all the same heartbeat here. So this one in lead 1, 2, and 3, and that's the same beat. Again, on this one, because we've got the 4th row at the bottom, this is just 12 seconds of lead 2. It's known as your rhythm strip, and that's the most useful kind of bit for looking at what's normal sinus rhythm, which we'll come on to in just a second. So leads 1, 2, 3. Augmented view right, augmented view left, and augmented view feet. So they're 3 extra views. You've got V1, V2, V3, V4, V5, V6. How do they kind of come about? So you've got 9 true views here. Don't forget the black lead of your limb lead is an earth cable, so that doesn't actually give you a view. We're looking at lead 1, 2, and 3 are true views. Augmented views are computer generated, so this is why you get 12 views in total. V1 to V6 are your chest leads, so C1 to C6. V1 to V6 are interchangeable terms. They are just looking directly at the heart from wherever they've been stuck on. So the ECG layout is then, this is when we get into the good stuff, isn't it? About when we look at changes in certain parts of the ECG, reflecting back to which blood vessel might actually be at fault. So this is a really useful diagram. If you're learning ECGs for the first time, just rather than learning the word septal there, just learn these all as being anterior. So V1 and V2, septal just means the wall between the left and the right hand side of the heart. So and V1 and V2 look at the septal wall, but technically we would still consider those to be anterior leads, okay, because they're looking at the front of the heart predominantly. So the what we're looking at here, do you remember these terms will look familiar? Because I said at the very beginning, when we looked at blood flow to the heart, we can look at 3 parts of the heart: the inferior wall, which was the bottom. We can look at the anterior wall, which is the front, and we can look at the lateral wall, which is the left-hand side. And hopefully you can remember then that the right coronary artery supplies the inferior wall predominantly. So if you saw loads of problems in these inferior leads, you would expect to find a problem with the right coronary artery. If you saw loads of problems in these anterior leads, V1 to V4, which obviously we've included septal in those as well, we would expect to see left anterior descending having the problem. And lateral, we find that they are, sorry, they're the remaining ones. They wrap around the left-hand side, and that's the circumflex. The circumflex looks after the left-hand side of the heart. AVR, you can see, isn't coloured in, and AVR isn't really used in practice that much. AVR is more of a test lead, because what we're looking for is that all leads are negative in AVR. That generally tells you that you've got your limb leads on the right way around. There is some evidence coming out, but I won't go into that at this stage because it's more kind of advanced than that. But there are some evidence around changes in AVR being quite useful in finding what's called triple vessel disease, so blockages in more than one artery. Hopefully that's making sense. So when the ECG prints out, every ECG will print out in exactly the same way. This looks much more like the ECG version that you'll see in an ambulance versus this one, which is more what you'll see in hospital. So whereas you see at the bottom there, you've got that 4th row, which is just 1 view for 12 seconds, whereas here you've just got 3 rows of 4 views. Good. So we're going to come on to what normal is. Hopefully I'm not confusing too many. Let's have a little look through there. So V5 and V6. Okay, so 2 schools of thought. There are, depending on which book you read and which cardiologist teaches you, some say you should follow the 5th intercostal space round. Some say you should draw a straight line from V4. I think in the UK we tend to draw a straight line from V4 more often. So what you're saying is also right. But yeah, you'll also see it written that you follow around the 5th intercostal space. Either or, again, be nice if everybody agreed on everything. So what do we call the normal sinus rhythm then? So we have 6 rules of normal sinus rhythm, and these are they. Okay, the first question you're going to ask yourself is it regular? So how do we spot whether a rhythm is regular? We measure the gap between the R waves. It's known as the RR interval. So if the gap between the R waves is the same, within a millimetre or so, it's allowed to change very slightly, then we would consider that to be regular. Okay, obviously if there was another QRS here and then not one until there, then absolutely that's not regular. Is the rate between 60 and 100? Now normally ECGs print out at the top the heart rate. Obviously if you're in any doubt, you just take their pulse or you stick the SATS probe on and get the pulse from that. But you can also estimate it from looking at the number of squares between them. I'll flip back a couple of pages. So if you divide 300 by the number of large squares between the R waves, you can get the approximate pulse, okay? So if we look at here, for example, so you've got 1, 2, 3, just under 4, let's call that 4. So what's 300 divided by 4? 75-ish, isn't it? So we know that it's going to be roughly 60 to, it's going to be between 60 and 100 there. But again, most of the time, the ECG machine is going to print out your heart rate at the top. This just means, so the ratio of P waves to QRS complexes is 1:1. So there should be one P wave before each QRS complex, one P wave before each QRS complex. Okay, we're not going to go into blocks on this ECG session or next week. That's for FREC 5 and beyond, and we'll do more webinars on those. But just bear in mind, if there's no P wave or there's too many P waves, you might have a block. That's something that's abnormal. The PR interval, we talked about this, 120 to 200 milliseconds. So that's the distance from the beginning of the P wave to the beginning of the QRS complex, should be 120 to 200 milliseconds. If I flip back a couple of pages, a small square is 40 milliseconds and a large square is 200 milliseconds. So we should be between 3 to 5 small squares, or up to one big square. So we're looking to see whether the distance between the start of the P wave and the start of the QRS complex is less than 5 small squares, but not too short. The QRS interval, the distance between the start of the Q wave and the end of the S wave, so the QRS complex, should be less than 3 small squares wide, 120 milliseconds. What we're saying there with these 2 points is that the 120 milliseconds to 200 milliseconds is the time spent being held at the AV node. If that's too short, the ventricles contract before they're supposed to. If that's too long, then actually the ventricles are being pre-filled for too long, and actually we're losing efficiency that way too. With the QRS complex, if the QRS is too wide, it means the ventricle isn't contracting quickly. When the ventricle is ordered to contract, you want it to do so quickly with less than 120 milliseconds. And then what we're saying with the QTC duration being less than 450 milliseconds is that we want the whole system to reset within a reasonable amount of time. So from the beginning of the QRS complex to the end of the T wave should be less than 450 milliseconds. Okay, that makes sense. QTC, so QT is the distance from Q to the end of the T. C is just corrected for rate, so you'll see it written as QTC. It's using Bezet's formula, which is really complicated and you won't be able to do without a calculator, I'm sure. But generally speaking, it's slightly different for men and women, but if you work on it being approximately 450 milliseconds, that generally works. And we're coming on to the final bit. You'll be glad to know, hopefully your brains aren't exploding from everything. But we've got to talk about, so we have normal sinus rhythm. What do we call it if it's too slow? Bradycardia. Brady, whenever you see brady means slow, cardia means heart. Tachy means fast, tachycardia. Sinus just means that it's still coming from the SA node, it's just running slow. We'll go into that in a bit more detail next week. But sinus bradycardia quite simply means that it looks normal, but it's slow. Sinus tachycardia means it looks normal, but it's fast. Okay, sinus tachycardia. And then there's another term that you'll certainly need to be aware of for your FREC 4 and useful for real life as well, is this term of supraventricular tachycardia, often heard just shortened to SVT. Supraventricular tachycardia just means, it's a very broad term, it just means that it's tachycardia originating from somewhere above the ventricles. So somewhere within the atrium there is a signal being fired too fast, okay, and it's causing the ventricles to contract too quickly. What makes supraventricular tachycardia different from sinus tachycardia really is it's faster, and B, it's so fast that you can't see the P waves. If you can't see the P waves, the rule is you can't call it sinus. So if you can't see P waves, it can't be sinus tachycardia, it must be supraventricular tachycardia. And the key is, if you're ever trying to compare the two, the supraventricular tachycardia is a lot faster than sinus tachycardia generally. But again, this can be from a variety of causes. So SVT can be caused by lots of different things. You're not going to be able to diagnose it until you can kind of slow it down and see what the underlying rhythm is. But sinus tachycardia versus supraventricular tachycardia, faster, no P waves. Okay. And that's it. Are there any questions so far? If not, we'll go into the quiz. So there's nearly 70 of you on here. It'd be really good to get as many of you as possible into the quiz. So no, only that, just that point about the positioning of V5 and V6. So fab. What we'll do then, let's grab your smartphones, go to menti.com. We've got 10 questions. So you're going to put in the code at the top. So 7304. 2617 and join the quiz. Please use your real names so we can kind of reconcile you at the end. The winner gets 10% off any course of their choosing. To win points, you answer correctly in the quickest time, so the fastest person to answer correctly wins. You only get 15 seconds to answer each question. Okay, made it quite difficult tonight. See how many we can get in. There's over 60 of you, so I'd like to see at least 30 of you in the quiz. As I say, 10% off any course of your choosing. If you have any questions, do throw them in the chats. We'll have a Q&A session after this anyway. Let's give you a few minutes. Once I start the quiz, nobody can join, you see. So if you want to get in, do so now. So good question, Nadine. No, as Matt answered, no. The underwire doesn't affect it. It's all shielded. So the ECG dots are insulated. So. Okay. Anyone else going to join? I'm just going to start. So we've been hovering about 25. Okay, fine. People are leaving now. So probably time to start. Okay, right. So you need to get your phones ready. Once I press go, you'll only get 15 seconds to start answering questions. All right, here we go. 25 of you. Where does blood travel to from the left atrium? Very good, very good. Nice easy one there. So left atrium, from atrium, it can only go to ventricles, goes through the mitral valve into the left ventricle. Very well done, 18 of you. It then goes from the left ventricle to the aorta, and pulmonary vein is blood coming into the left atrium. So let's see who got that one the fastest. Oh, it's on a go slow tonight. Doesn't bode well for 10 questions. There we go. Right, 2 answered correctly. That's in the lead. I know Matt's been desperate to win. He's been second every week since we started this. Well done, perfect. So Matt takes the early lead. Question 2. Have a look at your phones. Which coronary artery generally supplies the inferior wall? Very good. So it is, of course, the right coronary artery. The right coronary artery supplies the inferior wall. Left anterior descending supplies the anterior wall, and the left circumflex supplies the left lateral wall. So very well done, 14 of you that got that right. Let's see who got that right the fastest and see who's holding on to their lead. Okay. So Twitter's in the lead at the moment. Okay, who's next? So question 3. Which of these are the common side effects of an inferior STEMI? Ooh, inferior STEMI. So a difficult question. See if anyone knows it. Okay. So good on you. There's 7 people that knew that. So why is bradycardia so associated with inferior STEMI? I didn't say it earlier on. So good on you for the 7 that knew it. So the inferior, the right coronary artery that supplies the inferior wall generally also supplies the SA node. And if you make the SA node hypoxic, it slows down. All right, if the SA node slows down, so does the heart. So very well done for the 7 of you that got that. The most common side effect associated with, or one of the most common side effects associated with inferior STEMI is bradycardia, okay, and subsequent cardiac failure effectively, so cardiogenic shock. So who got that right? Perfect, Brian. Brian did very well there. Brian's taking the lead. Fantastic. Very well done. All to play for today. There's some difficult questions tonight, isn't there? Question 4 then, looking at your phones. What's a normal PR interval? Fantastic, very well done. 14 of you getting that right. Is it 120 to 200 milliseconds? Very well done. See who got that who got that correct fastest. Fantastic, Brian holding onto his lead there. Very well done. Perfect, question 5. All to play for, folks. We've seen it before. Turns around in no time. What does the T wave show? Myocyte depolarization, myocyte repolarization, ventricular contraction, or atrial contraction? Very good, folks. Very good. 11 of you getting that right. Myocyte repolarization. Depolarization is the act of contraction. Repolarization is during relaxation. That's during diastole. That is the T wave. That's everything resetting, ready for the next beat. So let's see who got that right the fastest. Brian's on fire tonight. Doing very well. Andy J. Very good. Excellent. Brian, Andy, Shivani in the lead at the moment. Very well done. Question 6. Which wave is produced by atrial systole? Some very quick people tonight. Very good, well done. The P wave, the atria contracting is the P wave, SA node firing, going down to the AV node and holding there until the ventricles are ready for it. So well done, who got that right fastest? Somebody was very quick there. Twitter, very good, very quick. Fantastic. Question 7. What is the term given to a heart rate of 36? Again, if you don't know it, sinus bradycardia, sinus tachycardia, asystole, or absolute bradycardia. Well done, 9 of you. Fantastic. So I didn't mention it, did I? So the heart rate, so sinus bradycardia is anything below 60. Ultimately, if it drops below 40, we use a new term. We call it absolute bradycardia, because generally speaking, anyone with a heart rate less than 40 is abnormal. So a heart rate of less than 40 is termed absolute bradycardia, as opposed to just being sinus bradycardia. So very well done to the 9 of you that knew that. Oops, what happened there? Where's it gone? There we go. Let's see who got that right. Emma, very well done. Emma was the quickest with the correct answer there. Fantastic. So Brian, Shivani, and Twitter in the lead there. Question 8. which of the following would suggest something other than normal sinus rhythm? Very good, guys. Very good. 15 of you getting that. So a rate of 99 could still be normal sinus rhythm. PR interval of 180 is perfect. Small T waves don't mean anything really. So a variable RR interval. Very well done. And that means the rate was irregular, so it can't be normal sinus rhythm. You got that right. Matt's back in the game. Perfect. Well done, guys. Fantastic. Question 9, all to play for, looking at your phones. What do we call a raised J point? Perfect. So yeah, raised J point would signify ST elevation. The closest correct answer there is going to be ST elevation MI. So you wouldn't get J points being raised in heart block. Sometimes they can raise in sinus tachycardia, but the correct answer there was ST elevation MI. If you guys see raised J points, that's what we're going to query until proven otherwise. So fantastic. Very well done. Let's see who got that right the fastest. Ryan and Andy J. Perfect. Well done, you two. Fantastic. Been neck and neck, hasn't it? Right. Last question then. There's a picture to look at. What is this rhythm? Well done. 22 of you got that right. Too fast to CP waves, supraventricular tachycardia. We can't diagnose it any more than that without knowing what's going on underneath. Who got that right fastest? Really is neck and neck, isn't it? Brian wins. Fantastic. Brian, is that the second time you've won? Okay, very well done. That was a very good score, actually, consistently good there. So hopefully you found that interesting. Brian, drop if you're the same Brian, then we've got your email. But if not, drop us your email, and we'll get you something sorted out. So I'm going to head back to here. So that's concludes tonight. What I'm going to do, let me just pop in the link for you so that you can get your certificates. Oh, I can't see my own screen there. There we go. Right. So if you all have a look at the chat box. Oh, come on. Bear with me. We're having the usual technological problems. Copy. Oh, computer says no tonight. Okay. Bear with me. No, it won't work. Fine. Okay, so in order to get your certificates, we're just going to have a look out on our Facebook page and on our website over the next couple of days. For some reason, it won't copy and paste the link into the chat box. So thank you very much for coming along tonight. I hope it's been useful for you, and I'm glad you've enjoyed the quiz. I hope it was a useful content for you. We'll be back next Wednesday, the 10th of November. So a week today at 7:30 again. We'll go into some more ECG stuff. we'll be looking at some more of the kind of weird and wonderful rhythms that we can come across when we're out there. Things you'll need for your FREC 4, things you'll need for real life. If you've enjoyed tonight, then please do leave us a review. It's really helpful for us if you can post on Trustpilot, Facebook, Google reviews, wherever you can, just to say that that you've enjoyed it. Obviously, tell your friends. We'd like more people to come along and see these webinars. If you're interested in doing a course for us, we'd love to have you along face-to-face up in Aylesbury. A few people just asking where the previous webinars are. They're all on our website. Go to stctrainingsolutions.co.uk, go to CPD Home, and everything is there, plus all the links to get your certificates for previous versions and things like that. I'm sorry I can't get the link to paste for some reason into this. Let me just, because we've been having issues with Microsoft Word since Windows did an update to Windows 11, and it's just causing so many issues. So let me just see if I can get our link up again for you. And well, welcome. I'm glad there's been a first timer along. Hang on, sorry, I'm having a moment. No, I can't, it won't, for some reason, Windows 11 is playing up. It won't let me copy and paste. So I'll pop it all up on our Facebook page tonight. I'll pop a link into the Facebook events that you all found us by to get your certificate. So apologies, I can't give you that at the moment. So there is a Q&A session now. I'll hang around for as long as anyone wants to ask any questions. If not, you're free to go, and we hope to see you again next week. So thank you ever so much for joining us. Gary, blame Jane. Very good. I like it. I'm glad you enjoyed it, folks. Not seeing any questions at the moment. Hi Diane, nice to see you. Big Emily. Big Emily will be making a comeback in the rerun of the ECGs. See you all next week, folks. Chuckle rhythms we'll talk about next week, Gary. Fab. So we're down to just a handful left now. So I'll stop the recording. Hopefully it's been